Hello, everyone. My name is Grace Suva, as you know, and I am one of the managers on the Implementation Science team at RNAO, and thank you very much for attending today's webinar. I'd like to introduce you to a few people. So I have myself, who is an implementation manager with the Implementation Science team here at RNAO, and I'd also like to introduce you to Andrea Stubbs, who is the Champions Lead for the BPG, for the Champions program. And in case you have any technical questions, please type in the chat box to all participants, and Andrea will be able to help you throughout the webinar. So, one of our monthly webinars is a means of supporting RNAO's best practice champions in their work in guideline implementation. And our speakers today are those who are actively involved in BPG implementation. And today, as you know, we'll be focusing on pressure injuries, the implementation, evaluation, and sustaining this best practice guideline. So just a few housekeeping items before I introduce you to our presenters. First, we want our webinars to be interactive and engaging. The presenters may ask the audience questions during the presentation, but there also will be a 10-minute question and answer session at the end of this 25-minute presentation. So we encourage you to type into the chat box a question or comment that I will share with everyone else and dialogue with on the Q&A. And we have also started to record these presentations so that they be archived for future viewing. So alongside with the archived presentation, we'll also send you at the end of the presentation a slide deck, which will also be available on the RNAO website. So today, I'd like to introduce you to our two presenters. We have Carol Williams, who you see pictured on your screen, and she is an RN who graduated from her BScN from McMaster University and is a member of the RNAO. She has over 28 years of clinical experience in the maternal child program as a bedside nurse and educator. And in 1999, she joined the Southlake team, and in 2017 transferred to the Professional Practice Department as Project Lead, Best Practice Change with a focus on patient safety initiatives. And at that time, she assumed the role of co-lead in the journey to become a best practice spotlight organization. More recently, she took on the role of Manager, Professional Practice, and Lead for BPSO, and in 2013, she received the Southlake Teaching Award of Excellence. And Carol currently resides in Newmarket with her husband and 3 children. So for those of you who are not familiar with BPSO, it does stand for Best Practice Spotlight Organizations, and BPSOs are healthcare and academic organizations who are selected by RNAO through our request for proposals process to implement and evaluate the RNAO's best practice guidelines. So it is a dynamic partnership that focuses on making a positive impact ultimately on patient care using evidence-based practice. And RNAO provides support to organizations such as Southlake that have formally agreed to implement and evaluate multiple RNAO best practice guidelines over a 3-year period. The second presenter I'd like to introduce you to is Anne Klein, and she is also a registered nurse, a Canadian certified wound ostomy continence nurse, and has completed a Master's of Clinical Science in the Wound Care at Western University. She is a preceptor for students from the Nurses Specialized in Wound Ostomy and Continence Canada, or NSWOCC, which was formerly CAET, and from Western University, and has been a speaker at several events. Anne was a reviewer for the Canadian Best Practice Guidelines for Ostomy Care and for the Assessment and Management of Pressure Injuries for the Interprofessional Team, so that's the RNAO guideline. She recently acted as lead for the implementation of Assessment and Management of Pressure Injuries for the Interprofessional Team at Southlake Regional Health Center, and Anne is currently the Wound and Skin Care Specialist at Southlake Regional Health Center, where she teaches and consults regarding policy in a variety of acute and complex wounds. So today is going to be a very exciting presentation, and I'd like to pass the floor now on to Carol and Anne to do your presentation.
Hi there. Can you hear me, Grace?
Yeah, we can hear you well.
Hi there. Okay, Grace, you can hear us okay?
Yes, we can.
Okay, terrific. I think I've just taken the ball and I can go ahead with our slides, I believe. So first of all, I would like to thank the RNAO for giving us this opportunity to share our journey to become a BPSO with all of those attendees that are out there. I see that there's 75 people logged in, so that's terrific. I also would like to do a big shout out to Brenda Mundy, who was our original BPSO lead when we started our 3-year journey. And she has since retired at the end of July. So she has passed the torch on to me, and here we are today. So on we go. So I would just like to talk about the session objectives today. And really, it's just to share our journey through our implementation of the best practice guideline with respect to pressure injuries. So we wanted to highlight some strategies for engaging stakeholders, the role of the BPG lead in this best practice guideline, and what the role of the champions was and is. We wanted to go over some of the tools that we used for implementation and some of the strategies we put in place. And then, of course, we continue to monitor and evaluate how successful some of the strategies we put in place. And, of course, now that we've actually received our designation, we are now in the sustainability period. So how do we continue on with all of the fantastic work that has been completed already in the last 3 years? So I thought we would just start with, for those that aren't familiar with Southlake, just if they're wanting to compare the size of the organization to someone else, who are we, where are we located? So we are located in Newmarket. So, for all of those out there that are from Toronto, there is life north of Highway 7. So we are in the heart of York Region, which is just about 30 minutes north of Toronto. And our hospital has actually been open since the early 1920s. And you can see some pictures from below from where we started and the nice fancy bridge that we have now. We have several programs that are regionally designated, and we actually serve more than 1 million people. So we do York Region, Simcoe County, in some cases as far north as Muskoka. So I won't bore you with all the stats because you can read slides, obviously. Right now, this number up here, 450 beds, is a bit of a fluid number, in terms of what we're funded at. And I think probably like most organizations out there, we are very, very busy and bursting at the seams. There's quite a demand for our healthcare services here. So as Grace mentioned, we are a designated BPSO celebration. And of course, this just happened in April of this year, and we're very, very proud of it. So the picture in the top left is actually when we were at the RNAO and we received our designation. So that's me on the left, and Brenda Mundy, who I recognized, is the second from the left. And then in the middle is Lori Reynolds, our director, and Annette Jones, who is our chief nursing officer. And then we have Rita from the RNAO, who helped us through our long journey. So in the bottom right-hand corner, we had a celebration event in May, which was a big media event, and you can see that Doris joined us for that. And one of the reasons we put this slide in is that it's really, really important to have the senior team really stand by you and endorse your journey through the BPSO and really support it. So the two people on the right, Arden Crystal, who is our new CEO, and Annette Jones, who is our chief nursing officer, are big supporters of the BPSO here at our hospital. So there were a lot of strategies that were put in place to engage our stakeholders right from the beginning, and then to engage our champions as well. So initially, our journey was simply, we started talking about BPSO at different committees. We have a nursing council, which is a representative from each of the clinical units that meets monthly. We have an interprofessional committee as well, so that includes all other allied health and does include some nursing as well. PCLC is our Patient Care Leadership Council, so that's where managers and directors meet. So, and then we had unit councils. So each of the units, or many of the units, have an interprofessional unit council that meets every couple of months to discuss issues that are on the unit or projects that they want to work on. And then we also did a direct approach. So we did things like elevator speeches and, talk to people, when we were looking at sort of our strategic plan, where we were going, when we were thinking about what kind of guidelines we wanted to implement, and then who would be the best lead. So some people were approached directly. And then we wanted to have some meat in it for people too. So we actually made them apply to be a BPSO champion. So there was an application form that they had to fill out. They had to express why it was that they wanted to be a champion, and it had to be endorsed by the manager. And we'll explain this a little bit actually when I talk about the monthly meetings. And then we would follow up with a letter to them thanking them for becoming a BPSO champion and what was going to be involved, and trying to keep them engaged. Then there was a champion development day, so it was a summary of the RNAO toolkit. So there were some individuals who actually attended the Summer Institute and were able to obtain the toolkit, and went through some of the key highlights on implementing best practice guidelines throughout the hospital. So they had some idea of, you know, how to engage stakeholders and some of the challenges that they may face. We then did monthly meetings. So this was twofold, actually. We had monthly meetings for the BPG Lead, so the Best Practice Guideline Leads, and but within the first couple of months, we started doing monthly champion meetings. So, you know, when you go on this journey, there is some funding for the RNAO, and we made sure that some of that money was spent on education for the champions. So initially it was about how to implement best practice guidelines, and then eventually it became, once we had some process and outcome measures, it was reviewing some of our data, strategies, and we would talk about strategies to improve or to further engage people. And then we also, eventually we ended up dividing the meetings, so we did the review of the guideline, and then we actually provided some leadership opportunities for the champions as well. So we would do some, we engaged organizational development to come in and talk about change management and conflict management and some sort of leadership skills for those people. I spoke about the elevator speeches as well, which again was one of the suggestions from the RNAO toolkit. And then at the 6-month mark, we did a check-in through a Survey Monkey to engage the champions to find out what was working well, how could we further engage them, et cetera. Again, we did a BPSO section on our Southlake intranet page so they could look at what was going on throughout the organization, and then if there was any interest for some of our champions who are working on one best practice guideline to be involved in another one. Annually, we hold a BPSO showcase, so all of the leads come together and do project display boards and show what kind of projects they've worked on, what successes they have had. And we also feel that recognition is really, really important. So again, having the showcase helps to recognize all of the good work that's done. And this year, during Nurses Week, when we did our celebration event in May, all of our BPSO champions got one of the badge reel holders, as you see below. And I've actually had people that, you know, come in through orientation, and when we talk about best practice guidelines, they'll look at me and they say, how can I get one of those badge reels? So it's a great starting point to engage people in conversations about best practice guidelines. We also did a couple of other things too. We did, you know, we've held the RNAO best practice, the champion workshops here as well, and also sent people to the Summer Institute as well. So here's an example of the champion application, and it's actually 2 pages. I know you probably can't read it. It's pretty small, but it explains a little bit about, you know, becoming a best practice champion. What does it mean? And then on the next page, you can see where they fill in their name, why they want to be a champion, and then endorsement. So the endorsement was really, really important from their manager, because when we were asking them to come to these 4-hour meetings every month, it was a means of gaining support from the manager so that the manager would help them replacing shifts if they needed the time off in order to come to one of the champion meetings. And I would like to mention that we adapted this with permission from Mackenzie Health in Richmond Hill, so this was not our original thought. So I'm just going to hand it over to Anne, who's going to talk about the BPG Lead in the pressure injuries, because she was the one that was voluntold.
Yeah, so yes, I was the obvious person to be selected to be voluntold for the this BPG. But of course I was happy to do it because there were many things I wanted to do in the hospital, and this was my big opportunity to get those things done. So it didn't matter which BPG we were doing, they generally went to someone who had some subject matter expertise. I feel, though, if you were set up so that that person wasn't completely available, you could probably have someone else do it with that person as a member of their team, giving them advice. So as leads, we had monthly meetings with all the BPSO leads, and this was pretty important meetings. These are important meetings because, for instance, we didn't start till year 2, but we were able to be in those meetings for year 1 and hear about everything that was going on with everything else. So, but when we started, we had a lot of good ideas that we gained from those meetings. We all did gap analysis and developed an action plan using the RNAO BPG toolkit. We also, all went to the champion workshops and became champions ourselves. And some people went on and did the part 2 of the program. So we had small working groups of champions, and then we all worked to develop resources for the staff in the hospital. And with BPG, it was kind of interesting because you'd start with one idea and it would snowball into many other ideas. So you'd start with one simple thing you were going to do, and as you were going along, you'd say, someone would say, do you think we could do this? And we go, yes, of course we can do this. And before we knew it, we had a lot of things on the go that were very helpful. Of course, we revised the policies and procedures in the hospital, went over them with a fine-tooth comb and made sure that everything was up to date. And we also had education days, which I'll talk about a little bit more. So some of the initiatives we had were we changed some of our policies in the hospital. For instance, we have risk assessment on admission and daily for all patients, so grade and risk assessment. We used to do them in the hospital Monday, Wednesday, Friday, but with the 2 days and 2 nights, people don't always know what day is Wednesday, so this turned out better for everybody if we were doing it just daily. And of course, it's an easy thing to do. It's what you do about the grading assessment. It takes time, not grading itself. Also, skin assessments on admission and daily on all patients. So that we would know if anybody had pressure injuries when they came into the hospital or if they were at risk. We did a project utilization poster, which we'll show you soon in the slides, that had all our products that we use in the hospital on it as a quick reference for nurses. And those products are all talked about in our policies and procedures too. It was just in a different format that was easy to hang on the wall on the unit. At Southlake, we do some different things. We are doing quarterly prevalence and incidence studies. So once a year, we go around with a big team and do prevalence and incidence. And we actually do prevalence and incidence. We don't do hospital-acquired pressure injuries. We do quarterly. We do a prevalence. We take a team and go around and look at everybody, and then we come back a week later and see if anybody's developed pressure injuries. And we do that once a year, but the other 3 times a year, the nurses do it at the bedside. And we do have the sheet that we use later on in the slides, and we can explain it more if anybody is interested. And if anybody would like to join us, of course, we'd like people to join us and make our data more robust. We did a pressure injury staging certification, which is on our SOLS, our online learning system, and made it compulsory for all nurses to pass this certification and for all managers to pass pressure injury identification certification. We did, again, we revised the existing policies and procedures. We invested in services and beds and heel boots for the hospital. And another thing we did differently here, often at hospitals, to get heel boots for patients, nurses have to call the wound nurse, and the wound nurse assesses and decides if they should have it. And we changed the criteria at Southlake so that heel boots were for any patient over 75 with a diagnosis of fractured hip, total hip replacement, stroke, or at nursing clinical judgment. And that was the important thing that we kind of snuck in at the bottom there. I've never gone into a room and saw a heel boot on a patient and thought, why did that nurse put that heel boot on? Nurses know when their patients need heel boots, so it's important we just put that clinical judgment in. So they're available on all units, and nurses can just go and get them, put them on their patients whenever they feel they need to. We redeveloped our surface selection tool with a criteria using the Braden score so that it was easy for nurses to pick out a surface. The other thing we did during this time too is we, in buying some new surfaces for the hospital, we limited our surfaces to pretty much 2 surfaces. So it was pretty easy to decide which surface your patient should go on. We got rid of all our regular surfaces so that we only have ones for people at moderate risk and higher. So it's an easier decision. We started doing instant reporting for all stage 2 and greater pressure injuries. And now we're doing them not only for stage 2s that occur in the hospital, but anybody who's admitted with a pressure injury, and for any pressure injuries that deteriorate. So say they go from a stage 2 to a stage 3, the nurse will fill out an instant report. So we can better keep track of them that way, and we, actually look at them to see what the root cause might have been for each pressure injury. We developed a wound care management poster, which I think I talked about a little bit already, a pressure injury management toolkit, which is in a binder in all units, and is now being put online on all the desktops so nurses can see them. And we now are celebrating World Pressure Injury Prevention Day every year, and we have a new theme every year. And last year it was feet, and we made a poster up about foot facts and got mirrors for the nurses so that they could easily look at feet. And we started doing wound care education days, which we were able to fund with our RNAO funds. We've done 9 so far, and we have 4 planned for this year, so 200 people so far we've educated, and we've done this whole day education for us. So here's the foot facts poster. And this was actually to remind people that they have to do they can't do the old neck to ankle head to toe skin assessment. They really need to do head to toe and take socks off and look at people's heads too. It's got funny things mixed in with good, serious stuff, so people are more likely to read it. And we also gave out swag. You can see it on the right there. Oh, it's not there. We used to have a picture up there of the mirrors we had made up with BPGO written on them that we gave out. This is the pressure injury management.
There it is.
Oh, there's a little picture of so this one here is the poster that we have on all the units, and plus we give all these papers out during orientation too, so that everybody has them. So this is in all the units, and it has all the products that we use in Southlake. It's a bigger one, so they can read it better on the units. For the education days for our agenda, we had the history of BPGs. We went through identification of Braden with using the Braden risk assessment, and had people being interactive and writing things down and getting up out of their seats. And we went through the interventions. We went through staging, so we're all on the same page. And we went through how they could manage those themselves, and also talking how to do back dressings at that time while we had them.
Actually, if you have a look at the picture that we provided on the slide, that's a wound. So Anne made all these fabulous wounds with different stages that we actually use on our education day, and the staff find them really invaluable. And it's a great way to do some hands-on experience with the dressing.
So as we said, we did our tool for selecting a bed, and I'm not sure we have that slide here. Just to make sure everybody was on the right bed in the hospital, we really reinforced that. And I guess it's on to you.
Yeah. So there are a number of options when you're looking at implementing the pressure injury best practice guideline in terms of deciding what are you going to be your process measures, your outcome measures, et cetera. So there's a number of things that we used to evaluate. So when we were implementing the mandatory staging certification, so it was the number of staff that had completed it, so what percentage of our staff who were required to complete it actually completed it. And our target was 100%, and we did actually reach that target. The number of people that attend the education days, we're often asked to share that information as well. Monthly, we track the Braden score within 24 hours of admission. The other piece you could track would be the Braden score daily. Now, we are a bit challenged with our computer system right now in that we are not able to track this, but we are lucky in that in December 1st, we're getting a new computer system, and we have actually built the report. So we can, it's a computer-generated report that we can get this information. And the same for the skin assessment on admission and daily. Right now, we don't track that, but we have a report being built. So in January, we'll be very, very excited because we'll be able to do that. We work very closely with our quality and risk department to look at the number of incident reports that come through. And in fact, Anne, as the wound care specialist, she gets a copy of any of them that are put through on pressure injuries. Prevalence, which we talked about as well too, so we do the prevalence and incidence study, and we have just recently started to look at hospital-acquired prevalence. So historically, we really didn't do too much with the prevalence. We were mostly interested in our incidence data, but now we are starting to look at that. And our incidence data is actually on our QIP, so that helps keep it at the limelight and keeps it to the attention of everybody. The other thing that we track as well is the use of rental beds, the cost as well, so we can keep track of do we have enough therapeutic surfaces in the hospital, and the use of heel boots. So again, we had to put a business case together, or we did put a business case together, so that the hospital now covers the cost of heel boots for those patients that require them. So your evaluation, for those that haven't been through this process before, is there's 3 types of evaluations that you can do. So there's your structural, so those are the attributes of the organization or your setting in which the care occurs. So things like saying it's mandatory, so that means it's supported hospital-wide, and that's where our completion of staging certification came in, and tracking of attendance at education days. Process measures, again, monthly we do this, so we look at the Braden score on admission, and eventually we'll be doing daily, and we monitor the cost of our rental services. And then, of course, outcome measures, we want to determine if all of this great work that we've done is actually working. And, of course, our outcome measure for pressure injuries is the number of patients that are actually developing pressure injuries in our institution on incidence. And, again, the other way we look at it is through our incidence reporting system for the reporting of stage 2 or greater, or those that have deteriorated, because that is now considered a never event. So if a pressure injury goes from a stage 2 to a stage 3, then that is reportable, and we have to do a full review in the hospital to determine why was it that patient developed it. So here's an example of one of the reports that we pull monthly, and this is what we share at our BPSO champion meetings as well. So this has each of the units on it, the number of patients admitted, and how many patients had their Braden completed within 24 hours. And you can see some units are really, really great, and then occasionally we look at how come this unit isn't doing well. And, you know, we've gone back and audited, and our educators have been absolutely fabulous in going back to see, we actually will get patient numbers behind this, so we can actually look up the medical record number and find out if it was done. And we actually found a little bit of a glitch in our reporting system. So if you look at MSR, so MSA and MSR is our musculoskeletal unit, and one of them is acute and one is rehab. So it's actually a way that our computer system was pulling the report. So it looks like MSR was really, you know, one of the lower units in completing the Braden. But in fact, when a patient goes from acute to rehab, we actually, in the computer system, discharge the patient and readmit the patient. But the patient never physically moved. So even if the Braden, so what we were finding was when they flipped over to rehab, you know, we were looking at the charts going, you know, the Braden wasn't done. And they said, yes, we did do the Braden. So it turned out the patient was actually admitted to rehab, say, for example, at 11:45, but the nurse had actually done the Braden at 11:44. So we're hoping with our new system, this will improve sort of our actual report generation, so we don't have to do manual audits on the charts. And that was the one I just highlighted. So again, this is another graph. You know, I'm a visual person. I like to see bar graphs, and I like to see the line move up because higher is better. So, you know, from January of last year up until April of this year, you can see this is one of the units. Actually, no, this is corporate, where we've gone. So we were just sitting at about 75, 73% corporately with our Braden, and now we're often almost up in the 90s in terms of corporately completing the Braden within 24 hours of admission. So as Anne mentioned, our quarterly prevalence and incidence study, this is the form that we use. And so what would happen, so on an interim study, the sheets are distributed to the nurses who are looking after the patients, and when they go to do their head-to-toe assessment, they would fill out the top portion of the form. So either no pressure, of course I've got the old form that says pressure ulcer, no pressure injury noted, and then the next week we go back, we look at how many of the patients we assessed are still in hospital, and we redistribute the sheets and the patient is reassessed to determine if they have developed a pressure injury or if the pressure injury has stayed the same or has deteriorated in that week period of time. There's just a little cartoon for you because we do work very closely with our quality and risk department. And then, as I mentioned before, pressure injury incidence is on our QIP. So this is what keeps it at the forefront of everybody's mind. When we log into our desktops or on all of the desktops, the home screen actually has this on it. So our target is 2.8% for incidence. And in our first quarter this year, we were actually at 1.9%, and we're just finishing up our preliminary data for Q2. Actually, is we were at 1% for our incidence. So that is actually a record here at Southlake. So we're very proud of that. So I just thought I would share some of the data that we share at different meetings quarterly. So this would be a result of the prevalence and incidence study. So one word of note, we had the most number of patients assessed during our prevalence and incidence study this year. So we had 399 patients assessed for prevalence, which for us, that is huge, considering it doesn't include our mental health population or our maternal child population. So that was a large number of patients. We had 40 patients who had stage 2 or greater pressure injuries and 62 injuries. So our prevalence at that time was about 10%, and last study we actually did look at hospital-acquired prevalence, which was about 6.5%. So a week later, we reassessed. 214 of those patients were still in our hospital. Again, that was a record number that we had ever reassessed. And we had 4 patients who had developed a new stage 2 or greater pressure injury. And we do a lot of work in terms of, was the patient sitting in a emerge on a stretcher for a long period of time? Was the patient transferred between units? Who looked after the patient? Was it agency staff who aren't familiar with our organization? So we look at sort of all the contributing factors. And of those initial 40 patients with pressure injuries, 3 remained in hospital, and 3 patients had an injury that deteriorated to a different stage. So again, as I said, 1.9% for our May study. So the nice thing is, so we do report our incidents and our Braden into the Enquire system. So this is, for those that aren't familiar, this is the RNAO system in which you can enter your data and you can print out lovely, you can do bar graphs, you can do line graphs like this one as well. So this gives us an opportunity to look at what are our trends, are we going up, are we going down, and we can share them with the units. So that's one from our musculoskeletal unit, and then this one here is from MACU. So you can actually see where the little diamonds are. You can see this is incidence. So on our MACU, we haven't had any incidents in the past 2 years. So this is terrific. Terrific news, and we can see that we are probably up in the 90s on MACU in terms of completion of the Braden on admission. So these show us that, our strategies are working.
So sustainability. Of course, all this work is for naught if we can't keep going. One big thing about sustainability that I think we were able to accomplish over this period of time is changing culture in the hospital, where people had a lot more awareness and a lot less satisfaction with having people with pressure injuries. Nurses just can't tolerate them now. They quite get up to that when patients have pressure injuries and they want to do something about it to prevent. So things that we do in the hospital to sustain our orientation. So we have an hour during our orientation, our corporate orientation, that's about skin and wound, and during that time we go through the pressure injuries to make sure everybody's on the same page. We all recognize what stage 2 pressure injury is, and they do the pressure injury staging test during that time. So they've all had that done before they go to work on the floors. We also have the toolkits on all the units that we made up, the binders, and of course on the computer desktops now. And we have the posters on each unit with the strategies to use for pressure injuries. Our online learning system, we have a module about Braden scale and Braden scale completion. We also have a couple of new ones that are just about to be put onto the system: management of stage 1 and 2 pressure injuries and management of stage 3 and 4 pressure injuries. We do monthly chart audits for Braden score completion, as we just said, and we report that to the units, to the managers. We participate every year and plan to in the future in Worldwide Pressure Injury Day, and we'll just have a different theme each year when it comes up with some project going on for everyone in the hospital. By keeping the pressure injuries on our QIP, or our quality improvement plan, we're sure that that's in the forefront and everybody's talking about it. And we also participate in the Joint Centers Always events. So this is a group of hospitals: Mackenzie Health, Markham Stouffville, North York, Michael Guerin, St. Joe's, and Humber. The Joint Centers are a partnership between these 6 large community hospitals, and they work together to find goals in common, so they can seek out and share innovative ideas and serve as a living laboratory to determine innovations. So if any innovations come up, we share those. Provide a forum for rapid execution of new ideas and improve importance. And together they come up with a group of things that we can all agree on that we should all do, which are things like the daily Braden score. That's something we can all accomplish.
And then again, as I mentioned, you know, for sustainability, we keep it on our QIP, so it stays at the forefront of everybody's minds. And then your best practice guidelines also align with accreditation standards as well, too. So this is one of the poster boards that was used at one of our showcases as well. And really just to remind everybody, for accreditation, there is a standard that says we have to teach clients and teach them their risk for developing a pressure injury, and we make sure that we assess and put interventions in place to prevent pressure injuries. So here's a nice poster board that was done. And then again, for continuing on sustainability, we actually have it as a standing agenda item on all of these, on the left-hand side, all of the committees, so that BPSO, although we've received the designation, the journey hasn't ended. So again, we have it as a standing item when we do a BPSO update at each of these forums.
Irma Jean would say, as evidence changes, we need to change our practice, but we should never change our belief in evidence-based care. So we always have to look at evidence, and kindly the BPSO looks at that evidence for us and finds what we should be doing. So when we started, we put this big paper up on the wall just to keep track of our journey so that we could see how we were going along. And this was the poster at our celebration at the end, and you can see how exciting it was to see all these things that went on. We were able to see all the work that we did. And other ways we celebrate our success, of course, we went around and took pictures of everybody, BPSO pictures, and we make sure those are up on display. And we recognize people through the hospital for the work they've done.
So that is the end of our formal presentation. So I guess we'll open it up to questions now.
Excellent. Thank you so much for that presentation. We do have a number of questions on the line. So let's just roll up here in terms of the first question. I believe one of the questions was on pressure injury staging certification, and if it is something that you created for training purposes or whether it exists somewhere else.
We created it ourselves. It's very simple. It takes people 15 minutes to do online. It explains what the different pressure injuries are, and then we have them write a very simple test. It's maybe 4 questions, but it's 4 important questions, and from that we know that they can recognize specific pressure injuries or the big differences, right?
Ah, okay.
We noticed during our prevalence and incidence studies, that was one of the themes that came out very commonly, was that people didn't chart the stage. So they would recognize there was a pressure injury on the patient, but people were reluctant and didn't have the confidence to say it's a stage 2 or it's a stage 3.
Okay.
Yeah.
Okay, and then I suppose like post-education, then people, and with the training and the check back, then they had more of the confidence to be able to identify as such?
Absolutely, and so the types of calls that I would get changed that came to my office. Instead of, you know, people calling frantically, the patient has a sore on their bottom and I don't know what it is.
Yeah.
I began to get calls saying, well, Mrs. Smith had a stage 3 pressure injury and this is what I did with it. See you on Monday.
Oh, excellent. That's amazing.
It's too bad we couldn't measure that confidence for our statistics, right?
Yeah, because that's great, you know, a great, I guess it would be outcome indicator as well in terms of, you know, the increased confidence and how that in turn impacts the patient care, because you were able to build capacity in a larger number of nurses.
I have to say, too, when we do the pressure injury test, everybody looks a little worried, and we encourage them to cheat a little bit with their neighbor nurse, but we explain it's not cheating, because as a nurse, you're never alone. As a nurse, you have your colleague there on the floor, and you can say, oh, come on in here, look at this pressure injury. What do you think of it? So we say, you talk to your neighbor during your test and discuss it.
Oh, okay. No, that's a great point. No, that's a really good point, and it helps to be able to create that you know, collaboration with your coworkers and be able to share learning. So it's another way to be able to learn aside from you delivering the content.
Yes, for sure.
Okay, excellent. There's also another question here, more so a clinical question. Perhaps, Anne, that you would be able to provide some advice on. What are the main causes of a wound to keep reopening at the coccyx, even though the wound protocol is being maintained?
Well, they could be like on the wrong surface, like maybe they're lying on their back. A lot of people think if they put their patient on a therapeutic surface, they don't have to turn them anymore.
Yeah.
It just kind of puts you on an even keel with a regular person.
Yeah.
But often friction sliding down the bed. So this was one of my big projects this year, was to get people to stop pulling people up in bed, because we think people should have their head at the top of the bed, the way we sleep at home. But really, they're supposed to have their hips where the bed bends. So if you keep pulling a short person up to the top of the bed, they'll just keep sliding down and maybe breaking open that pressure injury again.
That's true. So the friction and the shear. Okay. Excellent. Thank you. And another person here was wondering, when you talk about no incidents recorded at the MACU, did you mean that no new pressure injuries were observed with the same patients you were tracking, or overall with all the patients on the unit?
So that was just during our prevalence and incidence study. So that's a snapshot in time. So we do it 4 times a year. So during the study time period, so between prevalence and incidence in that week, that unit didn't have any patients who developed pressure injury during the study period time. Okay.
Okay, excellent. And I believe we have a comment here, actually, from Jamaica, so BPSO in Jamaica, saying, I like the idea of generating an incident report for stage 2 and higher pressure injuries. Are staff members compliant with reporting? I think this is something we could adopt in UHWI Jamaica.
Okay. Two of us are looking at each other. We both want to answer this question. So
you can both go.
Initially, we found inconsistencies with our reporting.
Okay.
We're working a lot closer with our quality and risk department, and we were finding, you know, on the prevalence and incidence study, there wasn't always a safe point incident report done on patients who we have found developed a pressure injury. We've started doing these education days for everybody, and and we've done the online education modules. We've reinforced that with everybody. We've put that message inside our toolkits. We've put it on the online education that an incident report is required.
Yes.
So since we've been doing that education over the past 2 years, I guess, our quality and risk department has actually, at first there was panic because, oh my God, we're getting way more pressure injuries in our hospital, but we're not. We're getting an increase in reporting because there's much more of an awareness of that's what our hospital policy is. So, and it's not meant to be punitive. Actually, our quality and risk department has just developed a trigger tool now. So we're looking more at what can we do in the moment. So rather than looking at our data a month from the month before about how well did we do, we're trying to identify patients right in the moment and put interventions in place right away. So they've developed, so once they get this this incident report, there's a trigger tool that goes back to the manager and educators, and they follow up in the moment to make sure that there are interventions in place so that this injury does not deteriorate to a further.
Oh, wow. So it also acts as a real-time, like a real-time measure as a means to be able to help patients while they're in hospital.
Right.
Oh, that's awesome. Okay.
And I get the reports too, so if I feel I need to go see them, I do.
Yeah.
Add them to my list.
And then do you keep these reports as a means to see trends over time as well, so they're used for a more bigger picture?
We can do that. We can print data from that system.
Yeah.
But I think we do it more manually because we don't have so many pressure injuries now. Like our prevalence rate used to be, what year?
20% in 2011.
2011, 20%, and now sometimes we're down below 2%.
Wow.
We've made a big difference.
Yeah. So. Okay, so it's not as onerous in terms of the the paperwork and the reporting because everyone's just doing so well.
Yes, everybody's doing well, and it's you can credit every nurse in the hospital for that.
Yeah, it's definitely a collective effort to be able to do this.
Yeah.
Okay. There is another question here, again, clinical. Do you utilize any additional interventions to help treat and manage pressure injuries, for example, ROHO cushions, mobility protocol, referrals to registered dietitian, et cetera?
We do. So nurses can refer a patient to a dietitian anytime they want. They don't need a physician order for that. And also they can call the OT and get special seating for their patient anytime they want. It's their decision what bed to put them on. I mean, I'm available if they need help, but we have a tracking system that they can go in and see where the beds are in the hospital and get one if they need one. We really give a lot of autonomy to the nurses and we're here for them, but they need to do that because I'm not here on the weekends at night. They need to decide what bed to put their patient on. But as I said, we've made it so we pretty much only have 2 beds, so it's either one or the other. So, but which one are you going to put them on?
Oh, wow. Oh, so that's great.
That's one of the initiatives with the Joint Centers project that we're involved in. So we've actually looked at, rather than looking at never events, we're looking at always events. So things that should always occur when a patient is identified to be at risk.
Yep.
So we've actually narrowed it down to 4 things. So one is the Braden on admission and daily. That should always occur. Skin assessment on daily and on admission and daily should always occur. And then again, if the patient has been identified with a low Braden score and has a mobility risk, the third thing we're measuring is, was there a referral to PT or OT? And then if their dietary requirements were a 1 or 2 on the Braden and they have a low Braden overall score, then again, the referral to dietitian should be in there. So those are the 4 things we're just starting to audit, and we're coming together with the Joint Centers to compare our data and put initiatives in place. We actually just finished our first audit on that as well, too. So we'll be meeting, I think, in the next couple of weeks with the Joint Centers to see how they are doing. So our focus is not so much now on never events. It's about things that should always occur for these patients.
Oh, excellent. Okay, that's excellent, and it's an ongoing process, as you said. Just because you've designated doesn't mean that everything stops. You have to be able to sustain, and the intervention and strategies that you're using continue to evolve over time with the changes that are happening in your organization.
Right.
Okay, we also have another question here related to pressure injury staging certificate for registered staff. Is there similar online learning available to your for your frontline staff, such as HCA or PSW, for recognizing first signs of skin breakdown?
So I would say yes. So we don't employ any PSWs right now or healthcare aides in our institution. Should that happen, though, and actually the online education was mandatory just for the nursing staff. However, we had actually more people complete it than just our nursing staff. We had about 1,500 people complete it. And
wow.
About 12 to 1,300 nurses. So I think some of our PTs and OTs actually did the staging certification as well. So it was just deemed mandatory for nursing staff, but anybody can actually log into the online learning system and just search for the course and complete the course.
Oh, that's excellent. Well, because the management of and assessing wounds is definitely an interprofessional endeavor. So the more people across interprofessional team can be aligned with what nurses know, that's great.
Right.
Okay, so let's hear. Let's see. There's a lot of great engagement here with your presentation. How did you plan to deal with any resistance to the daily braiding reporting that might have arisen?
There's always resistance, right? But I think showing them that it's so easy, right? I have to say, too, that our ICU, they do it twice a day. And I asked them, I said, why are you doing this twice a day? Your patients are at the highest risk. They can only get better. And they said they like doing the braiding.
Wow.
Well, it reminds them what it takes seconds to do. Like it's in our computer chart.
Yeah.
And it tallies it for you. It reminds them what to do for their patient for the day. So
yeah. I
think if you put it to people like that, like it's your tool for you, it's not just for the patient, it's for you as a nurse.
Yeah. That's a great point, and it's a tool that has proven to be, that is carefully chosen and proven to be useful and user-friendly, and easy to do, and that everyone seems to agree with in terms of the use of that, and has provenability. So the choice of tool also, I think, is very. I
would never
meaningful.
say we had 100% compliance. So you never.
Yeah. That's a pretty high standard to maintain or attain for, but you're definitely getting the majority of people who are wanting to adopt and embrace this evidence-based culture, so that's fantastic.
It helps sometimes when people call me about wounds, though, when I ask them as part of my routine questions, what's their braiding?
Ah, okay. So then when they call you, the expectation is, oh, Anne's gonna ask about the braiding.
Yes.
That's great. Okay.
So our ICU actually were one of the biggest groups that pushed back because they historically had really high pressure injury rates. And when we go back to them, they say, well, we're busy saving their lives. We're not worried about pressure injuries. And then, with the education that pressure injuries can actually increase their morbidity and mortality and actually make more work for them, and then seeing the great outcomes that we've had in the prevalence and incidence study. And then, of course, when you publish the data that, the ICU had 6 of their 10 patients with a pressure injury, whereas medicine program had 2 out of 200, there's a little bit of healthy competition going on within the organization.
Yeah, well. Definitely.
Right?
Definitely.
So, they were one of our biggest converters, I guess, so to speak, with completion of the braiding.
Oh, that's excellent. Well, yeah, it's the evaluation is very important, and the fact that you also bring it to the table and share it with frontline staff is very motivating, and forms part of the education and of the need of why you have to continue to manage these wounds very diligently.
Right.
Okay, so. Person says here, great idea about creating a PI staging certification. Is the online education available to anybody, or is it specific to Lake Ridge staff only? It would be Southlake.
Okay.
Yeah.
So, no, it's only available at Southlake, but we are happy to share anything we have with anybody who'd like it.
Okay. So just for everyone, the slide deck that you just seen today also has Carol and Ann's email addresses on the last slide, so they have agreed to also share their contact information with all of you so that you may ask, you know, some follow-up questions if you wish to this presentation. So thank you very much, Carol and Ann, for doing that.
Okay.
I think we have gone through all of the questions here, which is fantastic. Did you have any last comments or any other pearls of wisdom that the both of you can share with regard to this?
Well, I would say anybody that's contemplating going on the journey for BPSO, it is well worth it. You certainly see it in your patient outcomes and staff satisfaction as well as your patient satisfaction. Certainly, pressure injuries are something that should never happen in hospital, and there's been some great work done. So, you know, I would really encourage people, if they're considering to become a BPSO, to carry on with the journey.
Oh, excellent. Yeah, well, thank you very much. And I mean, you know, I was a BPSO coach for cohort 5 and, you know, listened to your journey as well as the journey of other organizations with regard to the BPSO and the implementation of best practices. So I must say that it's very impressive, the work that you have done, and you've hit all the key highlights when it comes to living out the knowledge to action process, when it comes to, you know, building that mass capacity of frontline staff and champions, to build in leadership and providing opportunities for leadership and autonomy amongst your nurses and your staff, and the importance of continued engagement and the use of evaluation. So, you know, congratulations to you for your continued excellent work. It's really impressive.
Thank you.
You're
I just
welcome.
see in the chat box people can't see our emails.
Oh, okay.
So it's our first initial last name at southlakeregional.org. So at southlakeregional.org.
Southlakeregional.org. Just .org? Okay.
.org, yep.
.org.
.org.
Okay. Okay, and I'm just going to type that in at southlakeregional.org. So for everyone who is asking about their email address, I just typed it in the, you're welcome. You're welcome. So just in terms of closing this presentation, thank you very much, Carol Ann, again, for sharing your lessons learned and your expertise today. That's very much appreciated. So just to let everyone know, a copy of today's presentation will be posted on the RNAO's website. And if you can please fill out the evaluation survey. If you're listening to this presentation as a group, if you can please email to Andrea Stubbs, and her email is on the screen there at astubbs@rnao.ca. If you can email the names and the email addresses of everyone who is listening in, if you are as a group, that would be greatly appreciated, so that she can send out a thank you and a follow-up to everyone who has attended today. So thank you very much, everyone, and I hope you enjoyed the presentation. It was certainly very informative and engaging, and have a great afternoon.
Thanks very much, Grace.
You're welcome. Thank you.
Thank you.
Bye.